So now we're streaming from the talk questions discussion room. Well, hopefully we're streaming from this room. So we're a bit early. So I would assume that some of the speakers maybe will only be joining at 2:30, which is in 11 minutes. But we already have a ton of people in here, including some of the speakers, which is really cool. So so Jitsi has this feature of you raising your hand. So if you have a question, maybe just click this raise your hand button in the bottom bar in the middle. And then I will try to keep track of who did that. And then you can ask a question. Who wants to start? No one? This is going well. Oh wait, okay, Maram, you go ahead. You may have to unmute yourself. So people generally join muted here.
Yeah. Hi, can you hear me?
Yes.
Hi. So yeah, I wanted to continue on the question of how to submit digital documentation for notified body, and I understand they require to be in PDF format. But on that topic, is there a specific structure that, like other people that have experienced submitting documentation that they have used, that the notified body accepted or refused?
So who would like to? So it's kind of very similar. So are you essentially asking if someone else has gotten away with something other than PDFs? Would that be a correct rephrasing of your question, or would that be wrong?
No, I understand it has to be in a PDF format, but the question, how did they structure their PDF documentation? Other people that have experienced submitting documentation that they have used.
Okay. So maybe one point which I can share is what I've seen in the past was like, it wasn't really structured extremely well, but what helps you a lot is to kind of create this table of requirements by either the standards, but also the MDR or MDD in the past, and then essentially noting which document or which PDF fulfills that requirement, which is kind of super painful, but I saw that this would be really beneficial generally for not only auditors, but also for the people in the company creating the documentation. So you would have like a line, you would have a spreadsheet. So Martin will be happy about this. You have an Excel spreadsheet, and you have like a line which is like ISC 62304, and then like maybe clause 551 or whatever, and then you have another entry which says like, okay, fulfilled in, I don't know, random file.pdf or so. So you would essentially map all the requirements to your to your files, and then it's kind of up to you what data you put into each file. But my experience again is extremely limited, and it may be that certain notified bodies have more particular requirements for file structuring.
Maybe I can comment very quickly on this. I saw very recently someone who collected all the different technical documentation structures from several notified bodies. I'm not sure if I can find that back if you're going to ask for it. But what I saw is that, and maybe Martin can also comment on this, is that a lot of notified bodies will actually provide guidance as to how that technical documentation should be provided to them. Honestly spoken, from my experience, and I know that under the MDD and previously they tried to do a setup from IMDRF by coming up with the stat format. I do feel that the stat format did provide some opportunities for aligning the setup of technical documentation. I think that under the MDR, there's room right now for regulatory authorities, maybe for the EU, and maybe again for IMDRF to come up with a reformatted format of the stat that fits much better to the requirements of nowadays. And I think that there's a gap, to be honest. And yeah, either MDCG could do something here or IMDRF, in my opinion.
Yeah, and I have a clear opinion around this. So especially the IMDRF activities, what we see is that they have created this table of content, and the table of content is supposed to be something like an ECTD, what we see in pharma. In my mind, it's not. So it's still very, analog, I would say. But you're right. stat was a very good thing to have in the past. And I think that is also the basis where the lawmakers put together Annex 2. I think there is some similarities between both, and structure-wise, yes, we have a guidance document available. BSI has a guidance document available. I think DECRA has one as well, and TÜV Rheinland as well. Typically, the structure needs to be clear and organized, and that is the only requirement, which makes it sometimes a little bit hard for manufacturers, because I believe manufacturers might like to have a standard available, but there is none.
Cool. So I hope I get this right. So we have 3 more questions coming up, and I think the first one to raise his hand was actually Christian. So feel free to ask a question. Okay, maybe he dropped out. Then the next one was Michael, I think. Oh, maybe like the thing is you have to unmute yourself. Oh, sorry. Yeah, yep. Perfect. We heard you briefly, but now not anymore.
Yeah, Michael, please go ahead. Yes.
Great. Okay, maybe you can. 1 second.
We can hear you now, if that works.
Okay. I'll just try it. So I have a follow-up question to Ivo's talk, whether you actually use this doorstep. I didn't quite get that, if that was just a recommendation or if you use that. And somewhat related to that, in the discussion, there was mentioned that you use Gherkin to do the requirements as well. And maybe that's a question to Martin. If you specify the requirements in Gherkin, that's also your tests. Is that acceptable?
So maybe we'll let Martin answer first, because I think Ivo is actually still at the dentist. So
unfortunate situation. Where you store your requirements doesn't really matter, as long as you can provide them in a format that it is readable to us. So if you have a possibility to export them in PDF, and I don't know if that program you're talking about is capable of doing so, then it should be fine.
I think maybe to also rephrase the question is, I think one sub aspect of the question was if your requirements can also be your tests at the same time. So for example, if you have a requirement which is like, I don't know, when I click the login button and it doesn't work, then like a red screen pops up or so.
Yeah.
Yep. And the test case would be described also. So because I remember
that's the language. Yeah.
Yeah.
It's kind of like it gets translated. Like you have code backing up this kind of language. Yeah. So you have to use like certain snippets of text, right?
Yeah. I know that there were and still are always a lot of discussions among requirements, test cases, and then the results of these test cases, because they need to be transparent to us. And they're often the systems you're using, which makes perfect sense, don't have that level of transparency to a human being, but that can become an issue in the review process. So I remember we had these issues years ago, and we still have them sometimes with also huge manufacturers who always struggle to give us the transparency we need around this. I don't know, maybe the specific case you're having is best to be discussed with an example, and then maybe under 4 eyes also.
Yeah, okay.
Cool. And I think I can actually redirect the question you had to Ivo. I can redirect that to Jauke, because he pinged me that he talked to Ivo and can kind of answer it.
Yeah, okay.
So they're phasing out doorstop. So it's doorstop, not doorstep.
Okay.
They're using a similar workflow. So you just export PDFs from whatever you've documented in your Git repository. Does it answer your question?
Okay. I wanted to know if that was a suggestion, like to use doorstop, or if they actually use it, like what he showed was that.
They use it,
doorstop.
but it's mostly a suggestion to do something like that that ties your documentation and your code base together.
Thanks.
All right. Next question, I think by Yang Chia. If I get the order right, I hope I got the order right.
Hi, everyone. So this is a follow-up question from the discussion as well. It's about the change, the design change. So really, whether we need to raise a design change plan from the very beginning or to have that evaluation completed before we release it to the market. I saw Leon's comment about having the changes evaluate at the end, so that's just before release. But what's in the standard is really to raise a design change plan. So I'd like to hear some comments, which is actually the best practice.
Shall I start with a brief answer from my view, since you referenced to me anyway in the comment, I guess. So how we, and I'm not going to say that this is best practice, but it's how we agreed upon this with our notified body, is that what we do is, especially myself and my regulatory teammate, is that we team up with the development team very closely. And from the start of where we have 2 weeks, so maybe I'm going a bit fast, but we have 2 weeks release cycles. So, but it's very unclear what will be included in every release. So, for example, if a feature is finished within the 2 weeks, it can be included up to the very last moment. But at the same time, they might find out that in the last week that they're not going to get a feature completed, and it might be postponed until the next release. And this is where I think the major issue is with following a very traditional process, where at the beginning of the, for example, 2 week cycle, you decide exactly what's going to be in the release, up to the moment of where you actually release the product. So how we do this and how we tackle this is that during the 2 weeks cycle, we start at the beginning of the 2 weeks by setting up a change impact assessment, which assesses what are the intended changes that are going to go in. And then we monitor what requirements are being changed and which verification and validation tests are required to be run. And then at the end of the 2 week cycle, we complete our change impact assessment by I would say that's about 2 or 3 days prior to the actual release. We have a final liaison with the development team where we say, okay, this is definitely going to be released. This is going to go in. And then actually the regulatory part bunches in most of the work. So that's where we start writing and updating all the documentation. So by that time, the development team should have run all the verification and validation tests for the features. And that's where we complete it. And then at the end of, actually with the release of the product, that's also where we sign off our change impact assessment. And this is actually where we also got challenged by our notified body who said, oh yeah, but you need to sign off on your change plan at the beginning of the 2 week cycle. And yeah, this I don't believe in it, because I think it's not reflective of how software development works per se. And I also don't see that there's necessarily a risk involved if you don't sign it off in the beginning of the 2 weeks, as long as you do a proper assessment at your release to make sure that all the updated requirements are retested properly. But this is my view. I'm not sure, maybe Martin, from a notified body perspective, you can comment on whether that's something you can relate to or whether that feels acceptable.
Honestly, I can't really comment on that because this is not really my business area anymore. So okay. I wouldn't feel comfortable in answering it.
Okay, clear. Does anyone else maybe have a view here on this? So yeah, just well, at the risk of everyone unmuting at the same time.
So you actually started the process at the very beginning. You and it's an ongoing process throughout the iteration.
Yes, exactly.
Yeah. Okay. All right. Thank you.
You're welcome.
All right. So we also have questions by Eric and Christian. I think Eric was first this time.
Okay. Hi. Yeah, Eric. I work for the ZORMAS project. I'm not sure if you know about it. It's like a pandemic management tool that's being employed in health departments. in Germany right now to go against the to go against the COVID crisis. And yeah, I'm no regulatory expert, but there was a question that sort of came up in my mind that might be relevant to our project one day. And I was wondering whether I could maybe ask this question in this particular format, because I'm not sure whether it directly relates to the talks that have been done so far. Would that be okay?
Sure, definitely.
All right. Okay. So following situation, so we are like a scientific tool, and we're not really we're not classified as a medical device, but we are thinking about expanding our functionalities with an additional module that could be interpreted as a medical device one day, and it would be not used in like every country that uses our software, and it'd be in very sort of specific context, so it won't always be available as a function. And the question that arises is, if you implement, or if we were to implement this module, would there be the possibility of separating it from the rest of the software, even though it is sort of integrated with it potentially, in a way that we don't have to do, let's say, a medical device registration for everything, but just for that particular function that can be turned on and off? And is there a way to segment that? And are there any maybe examples out there that of software solutions that had a similar predicament as we might have in the future, and how they dealt maybe with that?
So I maybe have a take on this, and this is interesting because it's probably the fourth most popular asked questions by companies ever. Like how to separate medical devices from other software, which may not be a medical device. I think generally it's possible. And in the case you mentioned, it definitely sounds possible. And unfortunately, there's a very high level answer, but you would need to ensure that somehow like the border between medical device and non-medical device is kind of a very strict border. So maybe to give you an example of something which probably wouldn't work is if you have like a mobile app, and the mobile app kind of is one like thing which is installed on a smartphone, and now you say, okay, it has different features, but I'm only going to like document the medical device features, and all the other stuff like login and all this other stuff is not a medical device, so I'm not going to document it properly. So that typically, I think in my experience, that typically doesn't work very well, because you can't argue that these two things, medical and non-medical device, are separated enough. And maybe an example of something which would work, which is unfortunately very crappy, is in hospitals where you have like the hospital information system, which is like for managing your patients and so on, which is often like not a medical device. But then you like open up maybe the lab information system for a patient where you want to see lab values from their blood analysis. And that opens up a separate application, and that possibly could be a medical device. Actually, maybe it's an IVD. Anyway, it's maybe a separate device which is separately regulated. So in your case, it completely boils down to how will this separation be done? Like, will it be a more or less separate application, or will it be so tightly integrated in your existing application that it's hard to argue that you can separate it? Unfortunately, again, super high level answer, but that's the best I have. Maybe someone else has a better take.
Maybe I can add a bit to this. Natasha Cooper from the Kiwa Dare Notepad body. Yeah, I fully agree with how Oliver explained it. It's also how we look at it. It should indeed, if it's a completely separate module, then it's definitely a possibility, but you have to be very careful in seeing how the other modules are affecting the medical module, so you should take that along. And indeed, if it's like the example that I absolutely agree with the smartphone app example, that you cannot simply say, okay, login is not part of it, because yeah, it's something that you need to do to be able to use it. So that's definitely part of the same thing, even though that function is not a medical function. The complete thing is indeed a medical device. But yeah, indeed, if you have a separate module in a larger package that is separated, and you address the possible interactions and how they affect the safety and performance, then yeah, you can definitely, it's allowed to do that as a separate module.
Cool.
I'm sorry,
thanks.
I would also add something. It's possible?
Sure.
Yeah, if you do this segregation on a software where you have a module that is a medical device and a non-medical device part, please also be aware that this has been transparent for the user. So this also has to be visible over the user interface. The problem is that segregation is very often done on a technical level that say, okay, the interface between components are working fine and everything is separated, as we already has discussed, in a way that it is working properly segregated, but it's not done over the user interface. And the thing is, I think what regulators claim at that point when you do segregation is that it is transparent for the user, because the user has to know if he's working within a medical device context or not, because that's due to risk, safety, and performance. So if you imagine that you have an application that, for example, has as you already mentioned, something that is organizing something like a shop system where you can buy medical stuff, which is not medical device, and for example, a rate calculator that calculates your dosage, you also have to show it on the user interface that these two things, aspects, modules, are separate from each other. And this can, for example, be done that you have a clear separation on the UI, where you have the CE marking on that module that is a medical device module. So keep that in mind, that it's not only on a technical level, it's on a documentational level where you have to segregate, and on a UI level.
Okay. Thank you very much for all the answers.
Cool. You're welcome. All right, moving forward, we have two more questions. I unfortunately cannot remember the order. So Bunty, maybe?
Yeah, thanks, Oliver. My question is for Natasha, and that is with regards to the clinical validation studies for the clinical decision support systems. We see with FDA where they have prescribed like standalone accuracy studies if for some category of devices, and they say you do reader studies for a certain category of devices, but we do not see this within the CE marking system. So how are notified bodies judging about what studies a manufacturer should be doing with the clinical decision support systems? Are standalone retrospective studies enough for proving and is there evidence enough, is the question.
That's not something that you can simply answer in this way. It really depends on a lot of things. It depends on the software, it depends on the intended use, it depends on what information is already available, maybe from equivalent devices, what is there on literature. So it's not one standard answer for one standard software device. You really have to look at the device and the clinical risk associated and what it does. Does it have a direct clinical claim or an indirect clinical claim? But in principle, the approach is that you have to do your literature review, or as it's called in the guidance documentation, to decide the valid clinical association. And that's mainly literature based. So, okay, this output is related to that medical indication. And then, of course, you have to show your technical performance. And then you need to show your clinical performance. And in most cases, that will mean clinical data. So that can be a clinical investigation, or it can be clinical data from an equivalent device. And only in some cases where only you have an indirect medical benefit, then you are also allowed to use Article 61.10, but these are very exceptional cases. So in most instances, you will need clinical performance data.
Okay, Natasha.
And of course, only if it's a medical device, because not all, of course, if software is not a medical device, and then it doesn't fit the MDR, and it will know that the body being looking at it. But it's the first step, of course.
Got it. Is there any MDCG guidance in working for defining what kind of studies the notified bodies want to look into?
Well, no. Well, there is an MDCG on the clinical evaluation of software, and there's a lot of information there, but it's general, because, as I said, you cannot make a specific guidance. You can only make a specific guidance for a specific device, but not for a general device group, because it's so broad. It can be anything from very high risk decision software with a direct diagnosis to very, very low risk, I don't know, care pathway, devices or something.
Thanks, Natasha.
I'd like to briefly add to this discussion, if I may, which is that maybe good to understand is that at standardization level, there is this similar discussion whether they can create ISO standards that might contribute to this, where it will be explained and which will provide some kind of guidance to what kind of level of clinical evidence will be required for which type of decision support software. But these are early discussions, and I can already see that this is going to become a very complex and difficult question. Same reason that you already mentioned as well, Natasha. There's so many different software applications with so many different indications. And how do you fit them all into a single standard protocol? It's very hard to do.
And I agree with you, Leon. I mean, at Cure, we face a very similar challenge. And I see with different notified bodies, it could mean very different and it could become subjective. So, yeah.
All right, moving on to the next 3 questions. And this time I got the order right. So it'll be Christian, then Yansha, and then Jauke. So Christian first, maybe. So you have to unmute yourself in case that's a problem. Now we can't hear you, I think. You may have to select the right microphone device in the Jitsi preferences.
Yeah, or maybe post your question in the chat and then we can respond to it.
Yeah, sounds good. So maybe you, Christian, can we hear you now? You're unmuted, but I can't hear anything, unfortunately. Okay, so how about you, Christian? You post your question in the chat, and in the meantime, Yansha can ask her next question.
Hi, sorry, it's me again. So this is a general question. For a physical conventional medical device, sometimes we have different versions for different countries. So I was just wondering if any of you have come across releasing different version of the software to different regions in the world, and especially when it is an app. Can you actually release different versions of the software as a medical device on an app into different regions in the world? Okay, seems like nobody has been through this sort of situation.
Yeah, we are. I think Jauke might, but I'm not 100% sure. Jauke, sorry if I'm showing you.
Yeah, no worries. We do, but we're not an app. So we're a website. So we have a selector that goes to the US version of the product or the EU version of the product. But I definitely understand your pain, and it's definitely not easy because regulations are getting a mess globally. Not really unifying.
All right. Yeah. So seems like this is an area that we maybe we can discuss about it later in Slack.
Yeah, we have a similar situation, by the way, where our features for the European product are slightly different to the version that we were releasing in the US. And yeah, same, I think, as for Jauke, right? So when we install the product for one of our customers, we in the back end, right, we make a selection on which region we're installing in. And then automatically those features will be exposed to them. And it's a bit tricky, right? Because if you make changes to some of the features that might not be available in the other region, and how are you going to do release management? Because then it's a release in one country, but it might be a release in the other country. So we decided that anyway, in any case, all releases are going to go to the same release process, whether it needs to be released in a single country or in all countries.
Yeah, that's also very interesting with feature flags, right? This is basically what you're describing.
Yeah, exactly.
How do you make a technical documentation for things that have feature flags? So you have conditionals on your PDF or something. It's really, really a minefield.
Yeah, so all of our requirements, for example, are marked with region labels. So we can differentiate per requirement, we can differentiate per test, we can differentiate per risk as well. But I have to say it's complex and it's hard to maintain, especially for our developers who are not always aware of this.
All right, thank you.
So Jauke, you had actually raised your hand earlier. So was something else? Yeah.
Something else, and that's automated testing. So it's a question to, I think, everyone. Like, how do you approach automated testing? Because I think what I raised in my presentation is you want to release very quickly, right? Once an hour is technically we could do it. It's just our QMS is in the way. But if we want to do that, then you need to have a lot of automated testing. So how do you guys see that?
I think what I can maybe share is, as long as the structure is fine and you can export it as a PDF, then you're already pretty good, right? So like, and the structure typically just is like, okay, you have a test, the test has like a unique ID, the test covers certain software requirements, for example, and you see which ones it covers. And then it has like some description, it has some steps in the sense of like, okay, in what state is the software before, what is being tested, what's expected. And as long as you kind of can create that sort of output with your automated tests, then I think you're already pretty good. So because then essentially your output just becomes the same like with a manual test, where you have like a test protocol where someone says, okay, this was the expected value and this was the actual value. And in this case, it's just software. And you bundle that up in a PDF and put it somewhere. That's at least my take on it.
Yeah, the feedback we got from our notified body is that, which is Stuf Rijnland, by the way, is that it's a big change from a quality management perspective. So, and that makes sense, right? It's you're basically getting smart people doing smart tests to stupid computers doing stupid tests. Yeah. So how do you make sure that it's still valid? Because I see your point. Technically, you can do it, but I think you can miss stuff. So basically, is there anyone in the group that says, okay, we have this under control, we've aced it, and our notified body is fine with it, the way we do automated testing?
Maybe I can, as a notified body, comment a bit on that. I've not seen any application where full augmented testing was used. What we do see is sometimes the simpler tests, or the more, how do you say, the less important tests, so to speak, are automated. And then for the important features, there's still manual testing. And I think that's acceptable. If I'm following up, as I said in my talk, I try to follow up the requirements up to the verification, but I mostly focus on, of course, the high risk items and the items that I'm not focusing on smaller details like, is the screen showing correct? Well, that can be large detail, but just trying to add there are a lot of requirements like just to make it handy to work with it. And if that's all with automated testing, and in the end there's some kind of usability testing showing, okay, it works fine, and if then that's fine with me. But for the important testing, you definitely want to see still how this is done and fully be able to follow it.
Yeah, I agree to
that's also how I see it in applications that is done that way.
Yeah, I see it similarly. But make sure that your automated test system is validated in your quality management system.
Okay, and then for regression tests, so if you do like a bug update on like a bug release, they can just reference to the previous test run. Would that be okay?
I would say so, depending on a bit, of course, on what did you fix and how likely it is. I think you can also use a risk-based approach in this instance. And so if you make a major bug fix that might influence the safety and performance, I would definitely like to see also some more of the validation or manual verification part. But if it's a minor thing and you can, in your risk analysis, you can determine that it's a very low risk for the, so to speak, important elements, then that's, how do you say it, acceptable. Yeah.
Okay. Thank you very much. Good insight.
Cool. All right. So actually, for me, then the interesting learning was that actually still most people are doing manual tests, which is, I think, very interesting because I thought like that many would have switched to automated tests, and it's just always me doing manual tests. But I guess that's not the case. So actually, circling back to Christian's question, which I forgot before asking Jauke, and now Christian posted it in the chat. So he said, here's my question concerning the documentation of software development before the first release. Is it sufficient to test extensively before the first release? So my take on it would be yes. So I maybe see this as possibly controversial, but what I always see is the first medical device of a new medical device company is the development always has begun when they didn't know yet that it was a medical device. So you always have some part of development while no one was aware of it. But as long as your documentation and your testing is complete prior to release or prior to hand in to your notified body in this case, then that's generally fine. But I'm happy to be corrected on that. If no one corrects me, can I assume that it's right?
There is a second part to the question of...
Oh, right. There's a second part. And the second part is that you can essentially, you don't have to document all your changes leading up to your first release.
Oh, yeah, same. Sorry.
Yeah, so
Yeah,
I would
agree.
Sorry, yeah.
I was just going to say that we don't document the change until we release it for the first time.
That's interesting. This is a very interesting topic. You know why?
I mean,
you know why?
Before it's released to the market, it's really a prototype.
Yeah. I totally get that. I've been there, more in the hardware world, but I've been there. MDR requires you to provide information that the design stages of your device are understandable to the reviewer. How would you do that if you don't explain through which pre-versions the software went? I mean, this is, I don't know the answer to that. I can ask this question because on the notified body side, you're paid for asking question. But how would you fulfill such a requirement to provide insight into the design stages when you don't talk about the changes?
I would probably just argue that like everything during research and development is kind of like this magical world where nothing is documented and everything's fine. And the real design stages start happening as soon as you've settled on like what you generally want to develop. And then you still can have a fair amount of design stages afterwards. You can say like, okay, now we've settled on the first prototype. Now we have like, I don't know, a conception phase, a review phase, a blah, blah phase, and so on. But I do get the point of your question, which I cannot answer the question at its core though. So this is a half-broken solution.
So can I just ask one question, Martin? A change occur when you have something in place, right? So if you don't have anything finalized, how do you define change?
Good question, but that is something that you need to take care of in your design and development procedure. Yeah, I mean, you have a staged approach per definition that you need to go through a staged approach. Now, at every review stage, you review a certain development level of your medical device. In stage one, it's maybe really a very nice prototype, and in the last stage it's almost the final design. Now, in between the first idea, so prior to stage one, and the final design, end of the last review stage, there will be iterations to the design of the device, and that, of course, in software might be more different than in a hardware developed device, but still it is something that needs to be documented because it is good design and development practice to document something like this, and also needs to be part in the technical documentation to a certain level. And how to document that, as I said, I'm in the lucky situation that a notified body cannot give recommendations, but it needs to be in a way that it is understandable to us. It doesn't mean that you need to document like every bit you're changing, but it needs to be understood that, for example, you take away a feature and how you made sure that removing a feature does not adversely affect the other features.
I think Natasha also unmuted herself earlier, so maybe, I'm not sure if you wanted to add something to one of the earlier questions.
No, not at this moment. I think,
Okay.
Yeah.
Cool. So I have one more question by Bunty, and probably this is also the last question because it's almost 3.
Thanks, Oliver, for allowing to ask this question. My question is again for Natasha, and it's in the interest of all clinical decision support device manufacturers. Is that is about again about the clinical validations? We as a manufacturer, we generally do clinical investigations in various countries, and suppose that is happening in Asia, and we prove that the clinical care pathway is the same, and we also see a lot of trend of open source data sets only in the AI industry, fortunately. So can we use European open source data sets and also add it as one of the clinical validation studies and say that yes, this our software also works on the European population? So is this something which would be acceptable to a notified body, is a question.
Yeah, in principle, the MDR does not say that you cannot use data from other countries or other, how you say it, regions. But you have to consider that the care pathways and other relevant clinical situations are comparable, and also, of course, the population. It can also be quite a different population, so you also have to look at that. Sometimes maybe you can indeed add some other data sets just to prove that the population is comparable. But if you do that all, and you also look at that MDR requirements have been met, like ethical requirements, then yeah, you can definitely use that data.
Thanks, Natasha. That answers. Hopefully, your view is acceptable to all notified bodies. Is what I would guess. Yeah.
I follow
right.
this view at least.
Cool. That sounds great. All right. So it's 3:01. We're nearly pretty much at time. So I'd like to thank all the speakers and especially Martin and Natasha for answering all these questions. I think this was actually super, super valuable for all the attendees here to get, like, if consultants like I answer questions, there are always like 1,000 different answers if you ask consultants. But if you actually ask people like you guys, then the answers are actually quite helpful. So I think that's really, really nice that you took the time, and also all the other speakers too. Also try to answer some of the questions in the chat in the meantime. So we'll be taking a break now of 15 minutes.